So I know all of you came to see Dr. Jonathan Leipzig, and look who you get to see. I'm so sorry. I don't think I'm woefully inadequate, I know, but it is what it is, you know? We don't get everything we want in life. And Jonathan, you can blame Jonathan for this, okay? It had nothing to do with that Microsoft glitch. It had to do with the airlines and, well, whatever. So we'll get going. So it's just a really cool session, and have the best people besides me. I mean, they're the best people who are going to really give awesome talks. Sarah Rinehart, I've known a long time, and she is going to, we work together on a registry, and she's just amazing in terms of guiding us in prevention. And we have Jimmy Kerrigan, interventionalist, who's going to really tell us how he uses this information from CT to guide his practice. So that's awesome. And, you know, my very good friend, Dr. Ron Blankstein, who I could be here for the entire lunch telling you how I think he amazing he is. So it's a really star-studded lunch. It's going to be memorable for all of us. We're going to say, remember when we went to that luncheon symposium and heard all that great talk? And, you know, we're going to talk about, it's an interesting time in CT, right? You know, we've been going along and doing a lot of visual analysis, but now we're really on the precipice of providing absolutely fantastic tools to really help you take your reading, your interpretation, your clinical guidance for clinical management of patients to the next level. You know, the roadmap analysis, looking at, this is given to you as part of using HeartFlow services, and you're focusing on the utilization and the guidance with stenosis, plaque analysis. My gosh, if you've been living under a rock for the last few years, this is what is really at the state of the art. Let's not trivialize plaque analysis, right? We have to learn how to use it. We have to learn how to integrate it into our practice, and we have experts that are going to help guide us. And then FFRCT. This is really and again, these are not my slides, but I'm going through Jonathan's. So I'm hoping I'm filling in all the gaps as needed. So FFRCT, a physiologic solution for understanding. And that's beyond the stenosis. I think there's a lot we can learn about what the length of a lesion, non-obstructive, which other factors can cause a drop in FFR as well. So, you know, a first look at how, you know, stenosis severity can really, if you had an automated, and this is how I look at it, so maybe it's kind of weird because, you know, I always have a tendency to look at things differently, as most of my work colleagues tell me. But if you had a tool that could automate, you know, your assessment and give you a better understanding of stenosis, which will do what to you? Well, it would create efficiencies in the interpretation, but most importantly, it would allow you to think about guiding management of these patients. So it's going to provide a nice augmented tool to shift you away necessarily and provide a consistent assessment of stenosis, and it's a highly accurate tool, as you can see on this slide as well. I think if anything can help you be the guidance of management, it's a great addition. You're going to be more valued in your healthcare system by providing that guidance, particularly to our generalists, right, who are not up to speed on all kinds of sophisticated cardiovascular care. So plaque analysis, what can I say? So I've done a lot of work on kind of, it's not a lot of it published, you know, do it for grants and things like that, where you compare some quantitative assessment with some kind of invasive measure, in this case, intravascular ultrasound. There's this paper that was published just recently in European Heart Journal Cardiovascular Imaging, which looked at comparing plaque analysis, volumetric measurements with IVUS measurements. And what's critical to this, even though I didn't make this slide up, and I'm going to tell Jonathan he really screwed up with this slide, what's critical about this slide is that we have seen in the literature published data showing total volumes of plaque are very highly correlated with total volumes of plaque on CT. What this paper showed, a very, very high correlation with non-calcified plaque. That's our big target, right, for treatment. We want to shrink that, we want it to go away, and we want to target those people being at risk. But that correlation between that was 0.85, 0.87, something like that. I have done those numbers before, and I can tell you 0.3, 0.4, 0.5, is not an unusual number. It's often not published because it's not good. That's the secret to science, right? You don't let anybody show the data that's not good. But this is the first time I've really seen it to be very highly correlated, which is cool. And then, I think it's nice that we have these nomograms. The first thing all of my colleagues at Mount Sinai say is, what is 100 cubic millimeter? What does it mean, right? And now we can go to this nomogram, which was published in JACC Imaging, I think a couple of years ago, 3 years ago. We can look at that and say, okay, here you are. Here's a woman or a man. Here's your plaque assessment, and this is what it means in terms of how they rank in their percentile rankings, which I think can be very helpful. As you start to use plaque in your own clinical practice, you're not going to have a baseline for reference. You're going to be able to read the literature, but you'll get a better flavor for this as you use it and integrate it into guiding your interpretation, which I think anything you can use is helpful. So, complete solution, I guess. I'm not a good marketing person, but this, I do think it is kind of really helps us to set the stage for better interpretations, better guidance in terms of the risk in the population and what you can do to manage the patient. So whoops, did I skip 2 more? No, I didn't. Okay. So if you could, if you want, go to this slido.com and use this number. We're going to ask some questions. I'm going to ask you a series of questions. I'll leave this up, and we won't make you raise hands because it puts you on the spot, like you were in grammar school, but if you could do that. We have some convincing to do. Depends on reimbursement. We're working on that too. So awesome. You guys are way ahead of the curve. How long do I give this?
Until the answers are right.
Until the answers are right. That's what I'm saying. Okay. Okay. So, FFR-CT allows for adjudication of the physiologic significance of anatomical disease. What value should be used to guide decisions around ICA referral? Again, when you see Jonathan, tell him this is a stupid question. Distal segment, binary response, FFR value distal to the stenosis in question, mean value of the distal FFR across all 3 vessels. So we'll let you give it some time. My 2 cents worth, they're all good solutions, but you have to know what they mean. A very distal FFR is quite different than a translational. So I think they're both informative. But nobody is doing this. Are you dessert or something? Do I move on? We have 48. We haven't seen any answers. Okay. I'm going to move on. Oh, there we go. Okay. Good deal. So in which categories do you believe quantitative plaque analysis can add incremental insight beyond CTA? Oh, look at you guys. You're amazing. There's no right answer here, guys. It's just, your patient population could be different. And our experts will guide you in their insight as well. All right, I think this is the last one. And this is Dr. Kerrigan's, how can interventionalists use CTA and HeartFlow to guide decision-making in the cath lab? This is a really interesting question. Determine what access site to use, determine what guide to use, to choose, determine which lesions are physiologically significant and which are not. That's an easy one, right? And enable shared decision-making with the patient and heart team. Some of these are easy choices, right? decide if plaque modification is needed. So, I think I have one more. All right. Basically, I think a lot of you said all of the above. I think that's it. So I'd like to turn this, Ron is next. So we'll turn this over to Dr. Blankstein.
Since half the presentations have failed so far at the conference, this is like a key moment. Yes, it's working here. Well, I agree with Leslie. This is really a terrific session. I think this will be a memorable kind of event because we're showing a very exciting product. In plaque imaging is really one of the big themes of this meeting. Every year when people come to FSCCT, they say, well, what's going to be big this year at FSCCT? There's going to be a couple big things, but no doubt plaque imaging is one of the big themes right now happening in the world of cardiac CT. So I'm going to show a case that's a fairly recent case from Brigham and Women's Hospital. And this is a case of a 32-year-old male. And I think all of you just reading that line, you're like, whoa, I don't do a lot of coronary CTAs in 32-year-old individuals. He has hyperlipidemia, was a moderate elevation in his LDL, but even more impressive elevation in his lipoprotein A, which was 230 nanomoles per liter. For reference, the inclusion for most of the clinical trials right now for lowering lipoprotein A is around 200 nanomoles per liter. He's a smoker, and he was referred for CT because a few months before at another hospital, he presented with an NSTEMI. So what really happened is he was smoking marijuana and had some chest discomfort, went there, and there's a minimal elevation in his troponin. So they told him, you just had an MI related to your marijuana use. And I am in Massachusetts where marijuana is legal. In our cardiology division, we're kind of involved in studying this. We've had a couple studies showing it's not as benign as a lot of people think it is, but that's not the topic today. The topic is plaque. So he undergoes a coronary CTA. This is using a photon counting dual source CT. On the left, you can see here the curved MPRs just to show you the RCA, LED, and circumflex. And I think you can see maybe some speckles of white stuff, some calcified plaque, but overall, certainly no obstructive disease. This is what we would call a CAD-RADS1, so minimal stenosis. You can see the axial images on the right as well for those who want to kind of look through those. But certainly the amount of plaque here, I don't know if anyone were to guess, but I think some people would say minimal. There's maybe a couple little areas of calcified plaque. It's not super impressive, but of course he's 32, so you'd say, well, for his age, it's impressive to have any plaque. We then analyzed this through the new interactive plaque analysis tool from HeartFlow, and this is shown over here. So first of all, you can see that we can toggle between FFR and plaque. So we look at initially FFR if we want to, but here we're showing the plaque. The total amount of plaque you can see on the bottom left here is 824 cubic millimeters. And we can now go through each vessel. This right now is showing us for the RCA, and we can kind of toggle between different vessels. And what we see is, I'll just go back a little bit on the video here, is the different colors actually denote different types of plaque. So again, we can switch back and forth, but when we're looking at plaque, and we're going to go through each vessel here, first is the LED as we're going down. The pink color is non-calcified plaque, the blue calcified plaque, the purple is low attenuation plaque. So you can see kind of circumferential non-calcified plaque in this vessel. And now same for the RCA, now showing the RCA, again, that non-calcified plaque was those little areas of purple, which is low attenuation plaque. So when we do this all together, we get a report that tells us what is the amount of plaque, the total amount, and for each vessel, how much of it is non-calcified? So there's a couple interesting points here. First of all, this is a very large amount of plaque, 824 cubic millimeters. So if I were to think forward to like CAD-RADS like 3.0 or 4.0, this would kind of put you at like a CAD-RADS P4. P4 is our designation for extensive amount of plaque. And you can look at the nomogram if you're not sure. So Leslie showed us the paper that this is based out of. And this guy is like completely off the chart because on this blue line here is the 90th percentile. So he's like way above the 90th percentile. He's way above the 99th percentile. But that's important if you're not sure. And then the other important point here is not just it's a large amount of plaque, but 90% of it, or 88 to be specific, but nearly 90% of it was non-calcified plaque. So this is mostly non-calcified plaque, and this is why when I showed you the case initially, maybe you saw a couple little speckle of calcified plaque, but that non-calcified plaque is more challenging to see. It's also less reproducible between different readers. And you could say, is that really non-calcified plaque? When I see a case that has that much non-calcified plaque, you could say, well, maybe that's just kind of noise because that can do it. And I'm going to show you now just my own images that I snapshot here to convince everyone who doubts if there's really that much non-calcified plaques. On the top here is the LAD on long axis, and you can see on the short axis, even this projector, which is not, or the screen, which is not super high resolution, you can see where the arrow where I'm showing this is extensive non-calcified plaque around the vessel. You can see that as we're kind of going down the LAD. On the bottom set of images is the RCA long axis and short axis. And if you can't see that this is what this is projecting, I kind of traced here. This is just my manual trace, this green line here, showing you all the non-calcified plaque. So this is really an individual with an extensive amount of non-calcified plaque. The third point is that 10% of it is low attenuation plaque. So that's plaque that has a Hounsfield unit that's less than 30. So as all these measurements, you can ask, well, is plaque imaging, does that really improve risk assessment? Can we just visually kind of take a look at how much plaque there is? And this is from an editorial led by Dr. Shayevich, who's here in the audience, that really summarized some of the impact of elevated lipoprotein A on plaque. Again, this is a young individual with very high lipoprotein A. And what we know is that when individuals have high lipoprotein A, they have more non-calcified plaque, they have more low attenuation plaque, they have faster plaque progression. And among those individuals, it turns out that the low attenuation plaque is a very important marker of higher risk. So at least in this recent paper published in JACC, it's really the individuals who had large amount of low attenuation plaque who were the ones who had events. So when we put this case together with everything I've just shown you, this is a CAD-RADS, well, one if it's minimal stenosis, or two if it's mild stenosis. But the key here is P4. This is extensive amount of plaque. And in the report, our interpretation is that there's an extensive amount of coronary plaque. The total amount of plaque is 824 cubic millimeters, which is more than the 99th percentile when adjusted for age and sex. 88% of the plaque is non-calcified, and the low attenuation plaque is 10% of the plaque. So generally more than 4% we would think of as high risk. 10% would really be a large proportion of low attenuation plaque. Based on this, our recommendation is, of course, aggressive risk factor modification in preventive pharmacotherapy, which I think in today's era, that's not just statins anymore, but that's a whole lot when it comes to lifestyle. In him, he would be a very good candidate for an LPA-lowering therapies, which are now in the pipeline, or at least get him enrolled in one of the trials. So take-home points from my case is that quantitative coronary plaque analysis can provide a quantitative measure of the amount and type of coronary plaque. The information can enhance the interpretation of coronary CTA, refine patient risk assessment, and help identify individuals who are more likely to benefit from more aggressive preventive therapies. So we can take questions maybe at the end because we'll move over to the next case by Dr. Sarah Rinehart.
I just want to thank everyone for coming. This is a packed room. I want to thank Leslie for everything that she does. And I think she really set up for this session very well with some of the things that she mentioned earlier in her talk this morning during the opening session. So how can we look at a case and really transform the care of our patients? So obviously we all have disclosures we want to go through, but you know, Leslie talked about CT has transformed the care. With Scott Hart, we showed that we're using aspirin and statins more appropriately, and it's consistent over 5 years when we started that therapy, and it's led to improved outcomes. But when we look at what cardiologists, internists, primary care physicians, what we're doing in the real world is not enough. Despite all of the pharmaceutical agents, but besides all of the imaging that we're doing, in our highest risk patients, who are those with events, who've had stents, revascularization, 2/3 of those patients have an LDL of more than 70. So we are not using the technology and the medicines appropriately. So how can we take all of this artificial intelligence and go beyond just treating the disease and the lumen to actually utilizing this plaque analysis so we can adjust our medications and target things on an individualized basis to actually prevent events downstream? So again, we've looked at all of the accuracy data earlier as well as the nomogram data that says we can actually have a personalized risk assessment that helps give the patient specific insights into their plaque burden and actually hopefully be able to show them and interact with them on a personal basis in their clinic appointments. So when we did the DECODE study, we actually tried to look at how are we going to use this product, and all three of us who were involved in this trial are in the room, and what we found is we chose a stage of therapy based off of a clinical CT report, and there were lots of insights. Number one, we found that some of the reports just really didn't reflect the amount of disease burden, and we actually changed medical therapy in 2 out of 3 of these patients. So 66% of these patients therapy changed just on the plaque analysis in addition to the CT coronary report alone. So one of the questions earlier was, well, do you do it in CAD-RADS 1, 2, 3, 4? Well, we actually intensified across the spectrum. And, you know, sometimes you can think of this as a bell-shaped curve. You may get the most of your benefit in CAD-RADS 2 or 3, but in the DECIDE registry, even in my own institution, I found that there's so much education across the board. Some physicians are aggressive, some people aren't. So the benefit to your patients long-term is probably more across the spectrum. And what we've also seen from prior trials is that there are certain plaque volume thresholds that actually help reclassify intermediate to high risk. So these are 2 of these trials, and these numbers, which is over 100 and over about 240, we incorporated these data into our extensive, mild, moderate plaque burden strategies. So we could actually put that evidence into a management plan for you. So this is a patient who came to see me just for the plaque assessment, to be quite honest with you. He's a 74-year-old Southeast Asian male. He has congenital heart disease. He was found to have non-obstructive disease, but he also has a lot of other risk factors, including hypertension and hyperlipidemia. And he had a remote CAT scan with only mild stenosis. He is a diabetic. He's got a family history of premature CAD, and he has anginal equivalent symptoms. He's on a fairly good regimen, but what I want to point out is that he was actually only on a Lipitor 20, but they de-intensified his therapy. He is on other very good medications as well. So when you look at his laboratory values, these are really fairly remarkable. Most of us would be very happy to have these results in our patients. The LDL is 45, the A1C is 6.1 on therapy, but he has a calcium score of over 1900, which is at the 90th percentile. So when you look at the roadmap overview, you can actually see he's got mild stenosis, there may be one moderate stenosis in that mid to distal right coronary artery. And if you look at the coronary CT, you can actually see lots of dense calcification throughout the epicardial vessels. You can see a lot of left main calcium, but the MLA was fine. But you also see this new higher risk lesion in the mid to distal right coronary artery. And remember, that was the one that was moderately stenosed. So as we look through, you can see the different views in roadmap. And again, this highlights that that higher risk plaque is the most significant stenosis that's present. FFRCT demonstrates there's no lesion-specific ischemia in this patient despite having a very high burden of disease. So when we look at his plaque analysis, there's lots we can learn from. So number one, his total plaque volume is over 1,200, which in our staging system counts for extensive plaque burden. What you are also going to see, though, is this disease is completely out of proportion to the LDL cholesterol. So is an LDL of 45 okay in this patient? So then we look at what's the breakdown of the plaque. Well, actually, a lot of it's calcified. It's 42% calcium. But in the right coronary artery, you have a higher low attenuation plaque burden. So we can use this plaque calculator to actually calculate the percentile. So again, despite having good numbers, he's at the 82nd percentile for his plaque burden. And when you look at this, this I find very helpful when I'm trying to say, what is happening to the plaque? Is it stabilizing? Is it more high risk? So this is what an average distribution in a male of his age were. You would have 76% non-calcified, maybe 24% calcium. So his is overall more stable, probably because that LDL is low. But remember, you still have that non-calcified. So despite being more stable, his statin was de-intensifying, and now he is starting to develop new plaque. So here again, you can see it's just mild diffuse disease. But if you see a report that just says moderate stenosis or mainly mild stenosis, you're going to underestimate this patient's long-term risk. So this is looking at that right coronary artery, and you can see there's low attenuation plaque, positive remodeling, which increases his risk. So as you're looking at the interactive plaque display, again, you can see all of these things that Ron demonstrated previously. You can go vessel to vessel, and again, you're going to see these different types of plaque going forward. So one of the things in the DECIDE registry we're trying to teach is how do we use this plaque information? So we determine these stages. Remember, I showed you those two studies with thresholds, and we can determine mild, moderate, severe, or extensive plaque. And we put the total plaque volume threshold for each of those stages. And whether you use a goal or a threshold, we're trying to put a target to inform the internist, family practice physicians, and cardiologists what we think the appropriate target or threshold should be for therapy. But if you have a high percentile, like our patient, or risk enhancers, he's Southeast Asian, he's a pre-diabetic or diabetic patient, we say go to the next stage of therapy because he has added risk. And then we put and highlight all of the treatment recommendations which may be appropriate for him. So his LDL is at goal, so you could think, okay, do I need to be more aggressive with his blood pressure? Do I need to address the diabetes? Do I need to look at his CRP? So it's highlighting, despite an LDL being a target, you need to look for where the residual risk is. So my question to you would be, how would you change your patient management plan based on this plaque analysis? Well, you could order a CRP, an LP(a), an ApoB to evaluate for residual risk. You could increase the Lipitor to 40 because the guidelines say 50% reduction as well as a goal of less than 55. You could add colchicine. You could add an SGLT2 inhibitor or a GLP-1 agonist. So we checked the labs. His CRP is elevated. his Lp(a) is normal. So we did talk to him and we increased his Lipitor to 40 to get that 50% reduction. He had an issue with gastroparesis. His weight was not overly obese, so we added an SGLT2 inhibitor, and we're going to recheck labs in 3 months. And again, if his CRP is still elevated, he may need an autoimmune evaluation or colchicine. So the reason I chose this case is I wanted to highlight it goes beyond the LDL of how we can actually change the management and potential outcomes for our patients. So this patient we know has higher risk plaque, and you may have a risk of a long-term event for this patient. We know that some of the best plaque features are the change in, or the delta FFRCT, the plaque burden, the total plaque volume, and the low attenuation plaque burden. So Leslie and Dr. Fuster and I are working on this DECIDE registry. We're super excited that we have launched it earlier this year, and we're going to see how this informs real-world changes in medical therapy to look at medical management compared to CT alone, but also after a delayed advent of the plaque analysis and also prospective. And we're going to look at outcomes, biomarker changes, and we have several sites who are open. I know several of you are here today, and we have over 1,800 patients enrolled. So we think this is going to really transform and educate us on how to use this product. I feel like the strength is we're actively learning every day. So, breaking news. I always forget about that I put this in here, but there is a Medicare coverage update where we actually just are looking at coverage, and I think the response period was just ended a few weeks ago. So when we're talking about that question earlier today, it's actually coming much more quickly than we thought it would. So I think we are all excited about the prospect, and I'll turn it over to Dr. Kerrigan.
Perfect. And I guess in more ways than one, batting cleanup today as the interventionalist in the room. Hopefully you're never calling me with the technology that we have available with regards to prevention and treatment nowadays. So we'll talk a little bit. Thank you to the organizers, to the rest of the panel for the opportunity to be here. We'll talk a little bit today from my standpoint in the cath lab. What am I looking for when the patient is referred for invasive coronary angiography, and how can I use the information that's being presented to make life easier for us and make the procedures potentially safer and more effective for patients as we move forward? So starting with a case. A 56-year-old gentleman with some past medical history, like most people in Middle Tennessee. He smokes, he's a trucker, he's obese and has high blood pressure, but generally avoids physicians. Presents to the emergency department with what could be anginal chest pain. It's substernal, it radiates, but to the right arm, and it's associated with seizures. In the emergency department, the physicians evaluate the patient and say, let's get a SPECT. So SPECT was performed from the emergency department, and what you can see is that there's an inferior defect with stress that's not there at rest, but it clears with attenuation correction. Interestingly, you get an LAD defect with the attenuation correction, but overall what the interpretation was that this patient was generally low risk. They were started on a PPI, and they were sent home with treatment for heartburn and GI follow-up and potentially psychiatric evaluation for their seizures. My wife's a neurologist, so I didn't refer to her. But the patient did come to our clinic. We do a next day ED follow-up for some of these patients as well. And he comes to see me where I talk to the patient and recognizing that he has risk factors above and beyond that than potentially Ron's patient who has an affinity for cannabis. I think that maybe there is something there that we need to investigate a little bit further. So in the ischemia trial protocol, in addition to titrating medical therapies, making sure that they are on antianginals, obtaining an event monitor to make sure these seizures aren't his heart stopping for periods of time, I requested a CCTA to definitively evaluate. I don't read CCTA, but we have a great group of readers at our institution who provide us the clinical support to get these studies done and then work together to figure out what it means. And because I'm not a reader, I don't have great axial views or MIPS for you guys to look at, and I apologize for that. But generally speaking, much like the patients we've seen before, the patient in their left coronary tree has what is interpreted as minimal disease, 10 to 20% in the left main and in the LAD. However, in the right coronary, the proximal vessel is moderate, 50 to 60%. In the distal vessel, they're 60 to 70%. So in a patient who's symptomatic, despite the fact that they have a low-risk stress test, we don't have to rush them off for invasive angiography. They don't have any high-risk features of left main or potentially proximal LAD, but this is somebody that I'm not going to say, go see that psychiatrist and the gastroenterologist, especially if you have continued symptoms. So what I'm looking for on the CT scan when I pull it up through our medical record before I see a patient or before I cath that patient, I am looking at what is my access site. If patients have an aberrant right subclavian, going right radial will make my day much longer. And then that's a situation where the left radial is usable as well. Does this patient potentially have surgical disease? Am I getting into a situation in a patient with multivessel coronary disease or a left main stenosis where I should have the conversation beforehand if we find that this is accurate? Is this a patient for whom cardiac bypass would be more appropriate than PCI? I know I'm an interventionalist, and it's nice to not be presenting to a room full of interventionalists because I would get run out for mentioning that in a different conference. Which sheath do I use? Some of the lesions, some of the blockages that we want to treat can't be done through standard approaches with a 6 French sheath. We might need 7 or 8, which would then put us in a situation where we've gotten one access and we need another. I can anticipate that with analysis from the CTA, and this is agnostic to the HeartFlow aspect of things. Which catheters do I use? Do I have an anomalous takeoff of the right coronary artery? Is there a bypass graft that I need to worry about? And how am I going to engage this, again, to make this procedure safer and more efficient, minimizing radiation and contrast? Which projections do I plan, especially using the HeartFlow tool to be able to see, is this LAO, RAO, cranial caudal? I don't know if anybody else practices in Ascension facilities, but early last year we lost access to IV contrast, so we had to be very cautious with how much we used on a case-by-case basis. For patients that had CTA, and especially CT-FFR beforehand, we were able to plan those procedures and minimize the waste. Again, the complexity. I think that we finished a joint SCAI session here recently, and we talked quite a bit about how do I use this information to decide what kind of treatment is needed outside of a balloon and a stent. Is calcium modification needed? Is this a case where potentially mechanical circulatory support might be necessary in order to safely treat this patient? And in that instance, is this a case that can be done at an ASC? Or is this something that needs to be done at a site with surgical backup where you have access to those tools and technologies? Again, hopefully avoiding unnecessary and potentially unsafe procedures for patients. And then for patients who come to me with angina or symptoms that are potentially anginal, even if the CTA is normal or negative, doesn't mean that we don't proceed to invasive coronary angiography, because potentially that patient needs to be tested for the angina with non-obstructive coronary disease, patients with coronary vasospasm, with microvascular dysfunction, with bridges, that we can now test invasively, modify therapies, and improve outcomes for those patients just by giving the diagnosis, not to mention the specific treatments that we have available. So looking at the patient's HeartFlow, looking in several different projections, compared to the other projections that we may have seen, there's a definite lesion in the distal vessel, and there's a definite drop in pressure across that, a significant translesional gradient. That proximal lesion, which was 50 to 60%, is not physiologically significant with only a 0.05 drop. Had I not had this information at the lesion-specific level, I might need to test that invasively with a physiology wire, making the procedure potentially more complex or more costly, putting on the administrator hat. Or some people would just stent it, and then the patient might get an unnecessary stent in the future, causing issues. Looking at the plaque analysis, you can see that the majority of the plaque is in the distal vessel, and what I want to point out, if the highlighter works, is that the majority of that plaque is non-calcified. So I don't have to worry about calcium modification tools. I know that this is going to be a relatively straightforward procedure. Looking at the distal vessel, this does not involve the bifurcation, so this is something that I can safely do with a 6 French guide catheter, allows me to pick my approach, my guide catheter, the site of care where I do this procedure. And then this is confirmation that the CTA was accurate. There's a hazy proximal lesion, which I know is not something that I need to worry about. I'm going to assess it anyway with intravascular imaging, and I think Carlos talked a lot about P4 and whether or not we need to use intravascular imaging. I would love to discuss that a bit further if time allows, but distally there is a severe stenosis, and from my standpoint, it's a straightforward imaging-guided PCI, where we're able to use a single stent after using appropriate intravascular imaging to define the size of the blood vessel before and after, optimize, treat, and leave that proximal thing alone because it's not physiologically significant, and I don't want to treat something that's not going to improve that patient's outcome. So since the procedure, the patient's done well, they have had no more heartburn, no more seizures, and I didn't treat something that didn't need to be treated. So thanks again for the opportunity to be here, and I think that opens us up for conversation and questions.
So please get your questions ready. Now you've all done with lunch. Now it's your turn to jump up to the mic and ask questions. 3 fantastic presentations. World-renowned experts here, and providing a lot of pearls, in my opinion, for cases and management of patients. So I wondered if does anybody have any questions before we get started? In lieu of that, yes, please. There's a mic right there.
Great sessions and really great talks. But I think we're facing the similar challenge in many programs. For instance, in my program, we deal with 6, 7 different sites, and each is equipped with very different level of technology, from old 64 slide scanner to all the way to high-res photo counting scanner. So the end product is that we deal with very different resolution. And so it affects greatly in terms of stenosis assessment, as well as probably more so on the quantitative plaque burden. So here we look at this chart saying, here's the cutoff defining high risk or low risk. But in reality, when you use different technology, the cut points is very different for each scanner the images produce. So for one program, such a HeartFlow, that we feed actually images from all 6, 7 scanner to this one vendor, and then we bring back the same report. But really, in reality, they represent very different level of plaque burden and stenosis severity. How do we deal with that as a clinician?
Yeah, no, I think it's very important to know that everything we do to CT, whether it's plaque analysis or FFR or any analysis out there, always requires good image quality. But fortunately, we're kind of in an era now that, due to a lot of the work from multiple vendors, we can achieve good image quality on multiple platforms. And you are right that there may be some small differences by different scanners, but actually the differences in plaque are not going to be substantial. It's fairly reproducible, and it's been validated across different platforms. I would actually argue that stenosis severity is going to be more important. So if you have a scanner with much higher resolution, in general, the amount of stenosis will be less, and there's papers showing that as you use, for example, photon counting CT, you may downclassify severity of stenosis. So I think your comment is more applicable to severity of stenosis, but when it comes to quantifying plaque, it's actually more stable across different types of scanners. So I think you said there would be very large differences. I don't think the differences are large. I think it's actually a very stable measure when you have good image quality across different scanners. Now, the one caveat I'll say, if you're going to compare, Leslie and I are involved in clinical trials where we're actually quantifying plaque and looking for very small changes with therapies, and I think for that, it is beneficial to scan the patient on the same scanner in very similar settings.
Yeah, I think one of the things that we should make people aware of as well is that when the company is validating, they're looking at all different qualities of scans and all different vendors, because they understand that limitation. So they're really trying to take each plaque thing to the next level, looking at just those issues. So I think, again, just as the FFR technology has gotten better, the plaque technology is always going to get better and more reproducible with time too. So, but I think Ron's point is probably the most well-made, concentrating more on just consistent good quality images, regardless of 64 slice or photon counting CT.
I don't know if Dr. Kerrigan wants to comment just on your experience in getting these referrals to the cath lab, if you have any insight here as well.
As long as the microphone doesn't want me to comment on that, apparently, from that standpoint. I think that the quality of the scan does matter, as long as we're controlling heart rates, of course, which may be less important on the Neotom Alpha than it is on some older scanners. The information that I need to make these decisions is really there and quite available, much better than 15 years ago looking at these scans, trying to decide how to treat patients in the ICU, et cetera. I think that from a procedural standpoint, again, the things that I'm looking at with regards to bifurcation, with regards to plaque composition, a lot of that does come off of the automated analysis, regardless of the scan quality. We also practice in a large multi-center system where the quality of the scans does differ. But I do think that there's added benefit for these patients, and that's why I try to get this on every patient that I can who doesn't have renal dysfunction and prevent it, because it is quite useful and potentially prevents unnecessary procedures, regardless of that quality. I'm going to move that away from me now.
Okay. Another question, yes.
Have any of you looked about cardiovascular and velocity cardiac fat in connection with that? Because we have some data where patients who have increased cardiovascular velocity have obstructive disease and those who don't, in spite of the high calcium score, are not obstructive coronary disease.
Yeah, I think those are really good points. I know we've had several presentations, including one this morning about perivascular fat. You know, I think that's a good point. And I think, you know, hopefully one day that'll be part of our armamentarium as well. And, you know, I think it's an intriguing idea, right? And as Dr. Blankstein, we use it in our research as well. So can we just chat a little bit about patient management? Oh, another question. Go ahead, please, sorry.
Just have a quick question. How frequent do you bring the patients back when we have this high plaque volume? And would it be different from high risk?
So the question is how often do you bring patients back to image? So, you know, I think it's a case-by-case basis. Certainly if someone has a large amount of plaque and you treat them very aggressively, if you don't think there's something different you will do, there may not be a lot of room for bringing them back, and we still need more data on that. On the other hand, if a patient is not treated maximally and you think finding that they're progressing more rapidly would lead to a change in therapy because you still haven't started that PCSK9 inhibitor and you're still not sure about colchicine and you're still not sure about GLP-1, then yeah, I think, so the key is if you think it could result in changes in therapy. Now, some of my patients, once I find they have a large plaque, they're like, they now have everything, they're super optimized, and for those I think it's more questionable about when, but certainly we need more data. There's a lot of ongoing work in this area.
I'll stay away.
Yeah, just keep them out of the cath lab, that's the important part. It's all about prevention.
Yeah.
Chopped liver.
So I agree. I think it's a case-by-case basis. So when I'm looking at it, I'm saying, if I'm going to rescan them, is it going to make a difference in my care? I think that's the first and foremost. But I do feel like if they have a significant delta across the lesion as well as high-risk plaque, I'm more likely to do a follow-up scan very quickly. So if you look at all of those risk-enhancing features that led to acute coronary syndrome, that delta FFRCT, plus the total plaque volume, the low attenuation plaque, those are the patients I want to follow closely. So those higher risk patients, I'm going to order something or I'm going to watch them closely. In fact, I tell them in my report, if they are continuing to have symptoms and they have those findings, I'd have a low threshold to either repeat a scan or go to the cath lab at that point.
Claudios Mikoviski. I'm just a country doctor in South Florida that does a lot of these, and I wanted to transpose some comments that Dr. Shaw made and you made about plaque analysis. Now, most communities around the country either don't have CT, don't have FFRCT, and have no idea how to use this. It took me 10 years and over 40,000 cases to convince the interventional cardiologist to use this. And you talk about the big thing being plaque, and the other big thing is we really haven't moved the needle in terms of morbidity and mortality in spite of what we do. Doesn't it make sense in terms of plaque and the importance, which I think is the next big stage of preventive cardiology and outcomes, and trying to find people who are not sick, because we're always taking care of sick people. And this is a very hard thing to sell to the general cardiologist, the community, using plaque. Don't you believe, or I believe, that the next big step may be in prevention and taking people that are not sick, they're not coming to the ER, where it would make a difference doing follow-up post-treatment? What do you believe in that versus the way that we work now, which is we're treating people who've had disease for decades.
I wish we could have recorded what you said. I'm going to segue.
I love to talk, I can repeat myself.
Okay, all right. I thank you so much for that. And I would like to let Dr. Blankstein answer this because he's organizing a huge trial. You know, we are on the same page with you. We have so much work to do in this space. And maybe, Ron, you can comment about your new trial.
Yeah, no, I think this is, of course, a room full of imagers and preventive cardiologists and a single interventional cardiologist. No, I'm kidding. No, there's actually many interventional cardiologists who are part of FSCCT, so not a single. But certainly, I think your point is very accurate. And as Leslie made the point in our keynote talk this morning, is we need to start prevention earlier on and identify individuals who have plaque that's still modifiable. And we are working on a large multi-center trial, and that hopefully the NIH will fund, but have various partners for this trial that will kind of move that paradigm towards identifying plaque earlier and treating it earlier.
Yeah, so I'm from NHLBI. I'm actually in the advanced technologies branch, not the clinical trials branch. But so my question is mainly for Dr. Shaw, but if anybody wants to answer. I should preface it by saying I am a champion of advanced CT technologies and all the different things you can do. But my question is sort of what's good enough? You know, if, for example, calcium scores can identify 95% of all people at risk for coronary artery disease, do we need these more expensive, more highly advanced technologies to be able to treat patients and to prevent coronary artery disease? And kind of another way to think about this is, you know, what would be the clinical trials that you would design to demonstrate outcomes, real, you know, randomized clinical trial says, if we use this, and that CT technology and post-processing and AI and all of these technologies, how do we change outcomes from the way things are today?
Yeah, maybe we can all give a quick answer to that because I think we all have a little bit different perspectives, and it's an awesome discussion, and that's actually where we are right now in the field, right? You know, I think I'm going to speak for myself, and we can go down. When we moved from like doing a lot of calcium scoring to looking at calcium scoring with CT, you saw a different flavor for what was going on in the patient, right? You now saw, you know, the burden of non-calcified plaque, and plaque calcifies over time. So you're going to look at a calcified plaque, and we don't have a good flavor of when that patient has purely non-calcified plaque. We saw this younger patient with largely non-calcified plaque. If you just did a calcium score on that, you would have gotten a very different understanding of that patient. And that's where I think the research needs to be confirmatory, and or the AI solutions. You know, can we find, you know, calcium scoring in terms of shape, radiomic analysis that we could allude to a greater burden of non-calcified plaque? These are the things that keep me up at night.
Yeah, no, the very sophisticated questions that require a lot more time than we have, but I'll say the advantages of a coronary CTA is going to be highest in patients that have a large burden of non-calcified plaque, which is why I showed that case of a young person with extensive non-calcified plaque, especially for the age of 32. The other advantage is following response to therapy. We cannot use calcium to follow response to therapy, and if a potential paradigm in the future we'll see are therapies actually modifying plaque. And that can, even though you think of that, say, well, that's kind of expensive, you have to do CTs, in the long run, that can actually save us money because then we give therapies only to the patients who respond or only to the patients who have like that large amount of non-calcified plaque or whatever metric we come up with. So it allows us to actually be more selective and avoid some of the expensive therapies that today we use sometimes less discriminately. There's more to it now. Your other question is like, what are the trials that are needed? I think we need like a whole session on that. But the key there is like treating patients earlier.
Yeah, I think, we know a lot from the calcium score data, but one of the things we knew is that people who progressed rapidly had events. I mean, Paolo Raggi had a study years ago that demonstrated that. But what we don't know from calcium when you're following those serial CTs, which is what Dr. Blankstein was mentioning, we don't know if they're stabilizing their disease or are they progressing their disease burden? And that's why that non-calcified plaque, the low attenuation plaque, is so critical. The other thing that I think about is, you know, when I'm seeing my patients is how can I use the information to justify my therapies, right? So just the fact that we have stenosis assessment, plus the non-calcified plaque, you know, there's certain thresholds that we're able to get those advanced therapies actually approved for our patients. But also I think the plaque analysis as well as the CT angiograms, again, I always say this, if you show the patient their images, they're gonna be more compliant. And if they see not just the plaque, but the type of plaque, as well as the stenosis, they're gonna be much more compliant with their therapy and have a greater insight into their overall disease burden.
I agree. I think that when we're talking about incremental benefit of these technologies with what is currently standard of care, thinking, Ron, to your patient as well, in many hospitals in this country, depending on what that troponin was, they would have gone to the cath lab. And they may have gone to the cath lab, have suboptimal projections, and we would have said, hey, your coronaries are normal because it's a luminogram. It's not an angiogram, and we don't look inside the wall of the vessel. So this patient may never have been started on the preventative therapies and then shows up a couple of years later with that ruptured 30-40% stenosis, something that we need to look at the benefit of, and we do it in clinical trials with intravascular imaging, but it's not routinely used. So I do think that there's that incremental benefit there. And as Sarah mentioned, printing out the report, showing you where you are on that chart, here's your plaque, put that on your carton of cigarettes next time you go to get one and think about it, or your butter, whatever your vice is, to try to modify those practices.
Just a quick question.
So I do some work in AIPC. I'm a medical student, but working with Dr. Choi at GW. Just wanted to ask, you know, with regards to non-calcified plaque and lipoprotein A, when we're looking to the future of the new iteration of CAD RADs, do you feel that non-calcified plaque and lipoprotein A will replace coronary artery calcium scoring, or be used in addition to what looks like coronary artery calcium scoring?
Yeah, so I guess the question is, will lipoprotein A and AI plaque assessment replace calcium score? So I think lipoprotein A, first of all, of course, is a blood biomarker, so I think very much incremental to like the imaging information. In terms of will this replace calcium scoring, I think it depends. In patients who already undergo a coronary CTA, yes. I don't think there's a need to do a calcium score in patients undergoing a coronary CTA when you can get a plaque analysis and see how much plaque they have. It's like in my mind, like an unnecessary scan. Now, certainly a lot of institutions do a calcium score with CTA today, but I think in the future, like, why do you need that if you're going to do plaque analysis? Now, for asymptomatic individuals who are at risk, I think you could be more selective. The younger individuals, those who have a higher burden of non-calcified plaque, patients with systemic inflammatory diseases, I think, you know, potentially the role there is even bigger for a coronary CTA as opposed to a calcium score. But great question for the future, and you and Dr. Choi may be able to solve that.
On that note, we had the hard stop down. We've got to send you back to your meeting and enjoy the rest of the conference. Thank you so much.